Yeah, please start.
Yeah, so we have even Dr. Soumen Das has joined. Hi, Dr. Soumen, how are you?
Hi, how are you?
I'm good, I'm good. So we were waiting for you to join before we can go ahead. So since you're here, I think we will proceed with our program. So good evening, everybody, and welcome all the speakers and all the delegates. So this is the 31st episode of Decoding GI and HPB Oncology, and on behalf of Max Institute of Cancer Care, I welcome you all. I'm Dr. Asit Arora. I'm the Director of GI and HPB Oncology here at Max Saket. So today we will be dealing with a very important and interesting topic, and that is the appendiceal tumors, the localized as well as the tumors which had spread to the peritoneal surfaces. And we have a very distinguished faculty amongst us to give a talk on this. So we have Dr. Aditi Bhatt, who is a specialist in peritoneal surface malignancies and has a lot to her credit in this field. I would request Dr. Aditi to give her talk. Dr. Aditi.
Yeah. Thank you, Dr. Asit. And thanks to you and to Max Hospital for this invitation. It is always a pleasure to talk about PMP and mucinous appendiceal tumors. It is, one of the most intriguing topic for peritoneal surface oncologists. And today, I mean, the message I was given was to just talk about mucinous tumors and not much about PMP and CRS and HPB. So this talk is going to be focused on mucinous tumors alone. I will not be touching too much of PMP or CRS and HPB in this talk. So mucinous tumors of the appendix are very intriguing because they produce this, and this is anybody's guess. This is huge PMP. We start off our surgical residencies performing appendicectomies. That's the simplest surgery. And then as surgical oncologists, the appendix is also the source of these very advanced and complex tumors for which we perform some of the most complex surgeries. So today I'll be covering the biology and pathology of mucinous tumors. It is not just the surgical complexity, but the disease heterogeneity and biology, which is also very difficult to understand. How to establish a diagnosis and stage these tumors, and a little bit about the management of tumors confined to the appendix. So the appendiceal tumors constitute 1% of all the intestinal neoplasms and 2% of the colorectal tumors. Mucinous tumors are the second most common tumors after the neuroendocrine tumors. There are several classifications of appendiceal tumors. In the last 40 years, since appendiceal mucinous tumors have become a known entity, more than 10 classifications have come and gone. The two classifications that I want to talk about today is the WHO classification and the SOGI classification. And most of the peritoneal oncologists like me prefer the SOGI classification because it is very simple, easy to follow, and reproducible by the pathologists. And our guidelines are also based on the SOGI classification. So if you look at the classification, broadly appendiceal tumors are classified as epithelial and non-epithelial, and this is the same in the two classifications. Today, our focus is on this set of tumors. So the epithelial tumors could be broadly classified as neuroendocrine tumors and non-neuroendocrine tumors. And a large chunk of the non-neuroendocrine tumors are the mucinous tumors. The colorectal type of adenocarcinomas and goblet cell adenocarcinomas are very rare. And of the mucinous tumors, the entities that we must be familiar with are LAM, HAM, MAC, or a mucinous adenocarcinoma, mucinous adenocarcinoma with signet ring cells, and signet ring cell carcinoma. So the incidence of mucinous appendiceal tumors, I'm talking about the primary tumors and not PMP, is very low. It is 0.9 per 1 lakh per year. This is, of course, Western data. We do not have any robust Indian data on this. 25% are adenocarcinomas and 25% give rise to PMP or pseudomyxoma peritoneale. While talking about mucinous appendiceal tumors, it is imperative that we understand what PMP is. Now, this term is used in many pathological classifications, but per se, it is not a pathological diagnosis. It is a clinical syndrome, and there has to be a clinical, radiological, and pathological correlation to make a diagnosis. The SOGI group defines PMP as the intraperitoneal accumulation of mucin due to mucinous neoplasia characterized by the redistribution phenomenon. What is the redistribution phenomenon? The cells follow the flow of peritoneal fluid and implant at sites where there is stasis of peritoneal fluid or there is a high concentration of lymphatics. These sites being the pelvis, the right paracolic gutter, the right upper quadrant, falciform, and the greater omentum. Typically, there is sparing of the small bowel. That is mainly due to increased peristalsis, that the cells do not stay and adhere to the small bowel. But in advanced cases, you will virtually find disease on every peritoneal surface. So there are some peculiarities of PMP. Because it is so very low grade, it was initially considered to be a benign condition, then a borderline malignant condition, and now it is considered to be a malignant condition. So when you see the diagnosis of PMP, it is not a benign tumor, it is a malignant tumor. Like I said earlier, it's a very heterogeneous disease, and there is a lot of discordance in the disease extent and symptoms, which leads to late diagnosis of the condition. All these have implications on the survival and potential surgical treatment, and it also has implications on the use of systemic therapies. Coming to the origin of PMP, 95% of the cases of PMP are due to a mucinous tumor of the appendix, and that is why we are having all this discussion. The other sites of origin of PMP are the ovary, colorectum, urachus, and pancreas. So now, since we are talking about mucinous tumors, anybody can guess that this is the appendix and this is some mucin coming out of the appendix. So what will you term this? Will you call it a mucocele? I'm not sure how many of the surgical students are familiar with the term mucocele. Or will you call it a mucinous appendiceal tumor? Well, looking at this, it could be either. So what is a mucocele? It is a cavity filled with mucin. And there are two ways in which it can arise. If this is the appendix, there could be some obstruction to the lumen of the appendix and mucus accumulates in the appendix. Or there could be a tumor that produces excessive mucin and leads to a mucocele. In clinical practice, majority of the mucoceles are Mann's or mucinous appendiceal tumors. And this is what is called a retention cyst. These cysts are seldom more than 2 centimeters in size. Earlier, mucocele, it was not uncommon to find a pathological report saying this is a mucocele. The message I want to give here is that mucocele is just a descriptive term. When you see an appendix filled with mucin, it is a mucocele, but it is not a pathological diagnosis. So how do these mucinous tumors produce PMP? Now, there are two components of this tumor. There is mucin and there is the epithelium. And the peculiarity is that both mucin and epithelium can invade the wall of the appendix and produce PMP. When there are many times where you don't see epithelium in the peritoneum, just mucin. But mucin is also disease in PMP. If there is a lot of mucin in the abdominal cavity, the cells have to be there somewhere. So when we stage PMP, the stage of the tumor is the farthest site of the tumor deposit. That could be mucin alone or cells alone or mucin and cells both. And the grade of the tumor exclusively depends on the characteristics of the epithelium. So taking it a little bit further, the grade of the tumor depends on the cellular and nuclear features and the architectural pattern. And there is another thing that we need to understand when we are talking about these mucinous tumors and PMP, that is invasion. And it depends on the characteristics of the stroma and the tumor stroma interface. So this is the typical epithelium in what is known as a low-grade appendiceal mucinous neoplasm. There is a single layer of epithelium that is cuboidal or columnar, or it could be pseudostratified. It looks almost normal except for the presence of apical mucin. The nuclei are basal, there are few nucleoli, no mitosis, and the cells are neatly arranged in a single layer, which is why it is often confused with a benign condition. So this is what it looks like under the microscope. And here you can see more clearly the apical mucin. What is peculiar about these tumors is the front of invasion. This tumor stroma interface, you can see there is a straight line and the stroma looks almost normal. So this is what is known as a broad front of invasion or pushing invasion, which is characteristic of these low-grade appendiceal mucinous tumors. And you can compare it with an adenocarcinoma. These are of course high-grade cells. They do not resemble the primary epithelium in any way, but look at the stroma. The cells are scattered, and this is what is typically known as desmoplasia. So the SOGI group of pathologists has laid down some criteria for making a diagnosis of LAM, and I would urge all those people who treat mucinous tumors and PMP to ask your pathologist to use this classification. Essentially, a LAM has low-grade cytology and pushing invasion, but it can proliferate and spread within the peritoneal cavity. It rarely produces distant metastasis, and most importantly, it is a malignant tumor and not a benign tumor. So when you receive such a diagnosis, and this is not an old report, this is a report that I have received within the last year, appendiceal mass, mucinous cyst adenoma, mucocele, this is wrong. You must go back to your pathologist or get the slides reviewed and ask them to use the appropriate classification. And I'll come to the AJCC classification later. There is another thing that we need to understand about these tumors. They could be perforated or PT3 or non-perforated or PT3 and perforated or PT4. Now, perforated and non-perforated is not a visual diagnosis. Of course, this tumor is ruptured, it is perforated. This is perhaps non-perforated, but this is a pathological diagnosis. This tumor again looks non-perforated, but if the pathologist looks at it under the microscope, there will be cells of mucin on the surface. So without a rupture of the appendiceal wall, the presence of cells of mucin on the surface of the appendix would classify a tumor as a PT4 tumor, which is a perforated LAM or HAM. Now, what about the spread? For both perforated, that is PT3 and PT4 tumors, the incidence of lymph node metastasis as reported by several investigators is less than 5%. But these tumors have a greater propensity for peritoneal spread. The perforated LAMs in particular, the incidence of peritoneal spread is more than 50%. So this is an interesting study in which 500 cases of patients undergoing CRS and HIPEC were studied. And The authors found that the incidence of lymph node metastasis in patients with mucinous tumors was just 4.2% as compared to 66% in the adenocarcinomas. And when they looked at the survival in patients undergoing an appendicectomy or a right hemicolectomy, there was no difference in survival. So if you have a lamb that you can resect with a clear margin, a right hemicolectomy is not indicated to address the regional lymph nodes. And these are our SOGI guidelines. This was a consensus carried out among more than 100 experts. Most of the times, at least surgical oncologists will receive a report post-appendicectomy. The typical presentation of these patients would be right iliac fossa pain, often considered to be appendicitis, and the surgeon goes in, finds a tumor, resects it, or some of them just perform a right hemicolectomy, and the patient comes to you with the report of a low-grade appendiceal mucinous tumor. So what do you do with this patient? You will get the tumor markers done. For these tumors, we get all 3 tumor markers done, CEA, CA99, and CA125. And even if imaging was performed prior to the surgery, usually it would be a scan performed in emergency, not of a very good quality. So either it should be reviewed or a fresh scan should be performed 4 to 6 weeks after the surgery, or maybe even before that. And now if there is no perforation, the surgeon has resected the appendiceal tumor, it is PT3, the margins are free, then such patients need only follow-up. There is no need to perform a right hemicolectomy for these patients. Very low incidence of lymph node metastasis, low incidence of peritoneal spread. It was 17%, 0 to 17%, but more recent studies show that it can be as less as 5%. What if the tumor is PT4 and if there is no peritoneal disease? Then again, a right hemicolectomy is not required, but CRS and HIPEC could be considered even if the tumor markers and imaging is normal, because a lot of times this early peritoneal disease is not picked up on imaging and the tumor markers can be absolutely normal. So you would perhaps discuss with the patient and his family that this is where you stand and give them the option of undergoing surgery or a close follow-up. If again, it is divided into acellular and cellular mucin PT4 tumors, and the incidence of peritoneal disease is more when there is cellular mucin. So the recommendation to perform CRS and HIPEC with patients who have cellular mucin on the surface of the appendix is stronger. Moving on to the next tumor, that is the next type of mucinous appendiceal tumor, that is the high-grade appendiceal neoplasm or a HAM. And in this tumor, again, there is pushing invasion. The stroma is absolutely normal, but these cells are high-grade. They do not resemble, they are not like the normal epithelium. There is no apical mucin. You can see these large nuclei and multiple nucleoli. This is another example of a HAM. This is what is called the Cribriform pattern. So in a HAM, the cytology is high grade. There is pushing invasion. It can proliferate and spread within the peritoneal cavity. We do not know the exact incidence of distant metastasis because this is a relatively new term. And 5 years ago, 6 years ago, we did not have this term. Most of these tumors were classified as adenocarcinomas. And another thing is that a HAM can progress to a mucinous adenocarcinoma. So again, these are the low-grade features. These are the high-grade features. It is not so simple as I've shown it. And you need a good pathologist to make a correct diagnosis. So what about the recommendations for a HAM? Post-appendicectomy, If it is a PT3, no perforation, the recommendation of our SOGI experts is a right hemicolectomy and CRS and HIPEC, and the same for perforated tumors with and without peritoneal disease. And how has this recommendation come? It is largely due to this study. Now, in this study, the authors took 62 patients who had already undergone an appendicectomy, and all of them had high-grade tumors. Post-operative imaging showed no disease. So they systematically explored all these patients, and 65% of the patients had peritoneal disease, whereas only 2.4% had nodal metastasis. And 14.6% of the patients had nodal metastasis in addition to peritoneal metastasis. So while treating these tumors, even if there is no disease, it is best to give the option of surgery that includes a right hemicolectomy, CRS, and HIPEC to these patients. I don't think for the HAM, since the evidence is limited, we just have one retrospective study. It is important to give the option of close surveillance also to these patients. And again, the interesting thing is, why are the authors recommending a right hemicolectomy? The incidence of lymph node metastasis is not very high, but when they looked at the distribution of peritoneal disease, majority of the patients had peritoneal disease confined to the region of the right colon. And beyond a right hemicolectomy, it was only in 25%, that was macroscopic disease, and microscopic disease only in 11.3%. Again, the incidence of isolated lymph node metastasis was low in the overall population. And so the authors recommend right hemicolectomy to address occult peritoneal disease and not the nodes. The next entity is a mucinous adenocarcinoma. Again, it is high-grade cytology, and the invasion is what we call infiltrative invasion or desmoplasia. It can proliferate and spread within the peritoneal cavity and produces distant and regional lymph node metastasis both. So the important point I want to raise here is that MAC should be classified as well, moderately, or poorly differentiated. Some pathologists use the term low-grade and high-grade mucinous adenocarcinoma, and it should be avoided. Now, if your pathologists, I've not highlighted the WHO classification here because it becomes very complicated to try and explain so much of the pathology of PMP. But if you use the term low-grade mucinous adenocarcinoma, some clinicians will confuse it with a LAM. And whereas some of these patients may benefit from chemotherapy, patients with LAM will not benefit from chemotherapy. So it could influence your surgical decision making also, and even your decision to give chemotherapy. So when your pathologists are classifying these tumors, ask them to use the SOGI classification or the AJCC 8 classification, and MACs to be subclassified as well, moderately or poorly differentiated, and not as low grade and high grade mucinous adenocarcinomas. So this is the recommendation for the MACs. Again, right hemicolectomy and CRS and HIPEC with or without a perforation. The next entity is the signature cell tumors. When the signature cells are less than 50%, it is a mucinous adenocarcinoma with signature cells. And when the cells are more than 50%, the signature cell component is more than 50%, they are signature cell carcinomas. The important thing is that this is a mucinous tumor with signature cells. And this is all extracellular mucin, and this is the cellular component. So when you are classifying them, you consider you will calculate the percentage based on the epithelial component alone. Because if you take the whole tumor, then it will always be less than 50%. And this is what it looks like during surgery. This is a typical mucinous appendiceal tumor producing PMP. Now this could have signature cells. There is no difference between there is no, you cannot tell on visual appearance whether this tumor has signature cells or not. But there are these signature cell carcinomas that arise from colorectal cancer, colorectal adenoma. I mean, they are the spectrum of disease in the colorectal tumors and gastric tumors. And this is the morphological appearance of the peritoneal disease in those tumors. This is you can look at this and say it is going to be a signature cell carcinoma, and the pathologist will confirm it. Another important thing that I want to reiterate once again, acellular mucin is considered disease and a manifestation of PMP. It is not a benign condition. It is not something that can be left alone and not treated. So this is another classification that a lot of pathologists prefer, and that is the AJCC 8 classification. Till recently, LAMs were not included in the TNM classification, but in the AJCC 8 classification, LAMs are included. And there is no T1 and T2 in a LAM, because submucosal fibrosis is essential for the diagnosis of a LAM. So if a LAM is confined to the muscularis propria, it is a tumor in situ, and a tumor that reaches the subserosa or mesoappendix is a PT3, invades the visceral peritoneum is a PT4 tumor. The rest of it is the same as the other adenocarcinomas. The M stage is important. M1A is intraperitoneal acellular mucin. So presence of acellular mucin in the peritoneum is M1A in appendiceal tumors. It is not a benign condition. M1B is intraperitoneal metastasis with the presence of tumor cells. And M1C is metastasis to sites other than the peritoneum. Another important thing is the same patient can have a different grade in different regions. This is all slides from the same patient. There is a ham in some areas. There is an adenocarcinoma in some areas. We often see these patients who have a low-grade tumor all over the peritoneum with few foci of high grade. Or there are multiple areas of high grade, some are ham, some are adenocarcinomas. And with some amount of experience, you can tell looking at the specimen also what is infiltrative, what is not likely to be infiltrative. Like this is part of the glissons, and this is definitely an adenocarcinoma. Probably here it may not have so much of infiltrative invasion or desmoplasia. So the message I want to give is, when you see such a tumor, you take a preoperative biopsy, you aspirate only cells and you aspirate only mucin, or you aspirate only cells. It does not mean anything. There could be high-grade disease elsewhere. So there has to be a correlation between the clinical condition of the patient, the imaging, and to the tumor markers, the biopsy, everything, to determine the grade. Like looking at this scan, there is scalloping, but the margins of the liver are smooth. You are not seeing any enhancing areas, solid component. So this is probably a low-grade tumor everywhere, but this is something different. See this infiltration of the liver capsule here. See this omentum. Look at the nodules in the omentum. Look at the nodules here. This is on imaging a high-grade tumor. Now, if somebody puts in a needle here and aspirates some mucins and no epithelium, or there in this area, maybe there is some component of low-grade and calls it a low-grade tumor, you are misled. So a preoperative biopsy has a limited role. We still perform it to confirm that there is some disease, to give us an idea, but we will not base our final grade on the pre-op evaluation. and it is determined only by the evaluation of the cytoreductive surgery specimen. So to summarize, post-appendicectomy, get a pathology review, ask your pathologist to use the proper classification or send the slides and blocks for review. Review the imaging or repeat the imaging. A colonoscopy is recommended for all appendiceal tumors and all 3 tumor markers. If it is a non-perforated lamb, only surveillance is recommended. If it is a perforated lamb, high incidence of peritoneal disease, especially with cellular mucin, low incidence of regional lymph node metastasis, no need for a right hemicolectomy, consider CRS and HIPIC. High incidence of peritoneal disease, lower incidence of lymph node metastasis, right hemicolectomy and CRS and HIPIC both should be considered. Same for a mucinous adenocarcinoma. And if there is any primary tumor with acellular mucin in the peritoneum, then a CRS and HIPIC is required. A right hemicolectomy, if required, if there is a lot of disease on the right colon and you cannot clear it without a right hemicolectomy, or the tumor is a high-grade tumor. It is possible that it is a mucinous adenocarcinoma and there is only acellular mucin in the peritoneum, or there is a ham and there is only acellular mucin in the peritoneum. If there is any primary tumor with epithelium, mucinous epithelium in the peritoneum, again CRS and HIPIC is indicated, and right hemicolectomy, the same reasons to perform it. I would like to emphasize yet again, get a pathology review and insist on the proper classification. And another thing, once again, if you also have to look at the margin. So if the base of the appendix is not free, a cecectomy or a ileocolectomy may be required. Another message that I want to give is when you take in a patient for surgery, considering it to be acute appendicitis and incidentally find an appendiceal tumor with peritoneal disease, do not perform a non-curative surgery. That is, you can perform an appendicectomy. The important thing is not to open up the retroperitoneum. When you perform an appendicectomy, you are not opening up the retroperitoneum. Whereas when you perform a right hemicolectomy, you are going to open up the retroperitoneum. And this should not be done in the presence of peritoneal disease, because free intraperitoneal cancer cells will be shed and they will get implanted in the retroperitoneum, and your subsequent surgery will become non-curative. So it is an either or. Do the minimum. Just take biopsies. An appendicectomy is okay, but not a right hemicolectomy. Even if you are seeing a lot of disease, you are very sure that a right hemicolectomy will be required later. But you leave behind all the peritoneal disease and just perform a right hemicolectomy, thinking you will come back and resect the rest of the peritoneal disease later. That is certainly not okay. So do the minimum. And this is one example. This was a lady, I do not have a preoperative scan, but she had PNP and the surgeon thought it was a splenic abscess. He did a splenectomy and looked at how the tumor has implanted. You can see here the renal capsule is involved, the psoas is involved. Though one can easily go and perform a nephrectomy and clear all this tumor, this subsequent surgery is going to be non-curative. It is going to be a R1 resection and not R0. You may call it CC0, but it will never be R0. I think I will skip goblet cell carcinomas. I thought of talking about it, but we can do without it. So to conclude, tumors of the appendix are mucinous tumors of the appendix are very rare and heterogeneous. Proper pathological diagnosis is essential. Take a second opinion, review and repeat imaging when required. They require multidisciplinary management, discussion in MDT with your radiologist, pathologist, medical oncologist. discuss various options with patients and their caregivers, and tell them that most of the recommendations are based on limited evidence. And PMP is one disease where within each cities, we as surgeons need to have reference centers. We need to refer to our colleagues who are more experienced and not try to do everything, even though we may have the skills to do it. So I have written a lot about these tumors in these two books. And if you would like to have a copy, you can send me a mail. Thank you for your attention.
Yeah, thank you, Dr. Aditi. That was very comprehensive. It was down to the T. You have described it so immaculately, all pathology and the basics of what a surgeon needs to know and how he should be managing these patients. And I have read your book. I haven't read it completely, but I've read few chapters, and it's beautifully written, and I really enjoyed reading the book. So I'm really glad that you haven't covered a few of the topics which I think we will discuss during the during our panel discussion, especially some of the aspects of pseudomyxoma peritoni. So I would.
So, Dr. Asit, I wish to ask some question. Hi, Dr. Aditi. This is Dr. Shefali. Sorry for joining late. I was stuck up in the hospital. So I just wanted to know that you pointed out that there are non-perforated lamps which just need a surveillance. And it's all the radiology, pathology, and the clinical assessment which guides you, I mean, how to deal about it, whether it needs some proper surveillance. So what protocol of surveillance do you follow? And how frequently do you do some scan, or when do you like to intervene in such patients?
So these, our Sogi, I have not put that in the talk, but in the same paper that I was talking about, we have guidelines. So it is 6 monthly tumor markers and cross-sectional imaging. In my personal opinion, I think you don't need to subject them to a CT scan every 6 months, maybe annually. If the tumor markers have remained absolutely normal, you can just do an ultrasound and a yearly CT scan. Now, the important thing is that many of these tumors could develop disease beyond 5 or 6 years. So at least once a year surveillance should continue for 10 years or even beyond.
Right.
Yeah. What's your take on MRI? Do you find MRI better than CT for some of these early diseases? And at times we can differentiate mucin versus non-mucinous deposits better on MRI. So what's your take on
so a peritoneal MRI we follow since the last 2 years. We use a peritoneal MRI. That is a separate protocol as compared to the whole abdomen and pelvic MRI, and it is very good for these mucinous tumors. So if a patient is coming to my hospital and following up, I would ask them to get a MRI done as opposed to a CT scan, because a small nodule mucinous tumors especially would be picked up better on MRI. But if you don't have the facility, then a good CT scan. So it depends if you,
Right.
But MRI is certainly better.
Yeah, absolutely. I think I'll agree to that. So I think we will start with our panel discussion. I'll share my screen. So is my screen visible?
Yes.
Okay.
Yeah, Dr. Asit, it is visible.
Thank you. So we have this esteemed panel with us. We have already heard Dr. Aditi, and we know that she's such a thorough speaker about peritoneal surface malignancies. We have Neeraj, who's a very dear friend of mine, and he has special interest in peritoneal surface malignancy and its treatment. He's one of the first people to start CRS HIPEC in Delhi NCR. We also have Dr. Soumen Das, again, somebody who has a very keen interest in the management of these diseases, and Dr. Aruna Prabhu. Likewise, she shares a very keen interest in the management of these tumors. So I will just skip this, which has already been discussed by Dr. Aditi. So what I'll do is here, I'll use some of these cases, and I would like to have each of your opinion of as to how we are going to proceed with such a patient. And in the process, we would like to elaborate some of our clinical practices. So you have to realize that this program is basically aimed at teaching of our postgraduate students. So I think we will keep it to the basics, right? So a patient, 46 years, and she was getting worked up in a gynecology unit, and she had menorrhagia, and she was detected to have a lesion on an CT scan. So if you can see the scan in the right iliac fossa, there is a distended appendix, and following this, a CT was done. So this is the scan. If you can have a look at it, I'll just scroll through this. So basically, few some fluid, and there is this large distended appendix, which possibly is, I don't know whether you could pick it up or not. So this is what CT revealed, that there was a large, well-defined cystic structure in right iliac fossa, which is almost reaching up to the inferior border of the liver and causing indentation. Now, how would you like to proceed further in this patient? So I'll start with you, Dr. Aditi. What additional information would you want, and how are you going to proceed in this patient?
So in this patient, colonoscopy and the tumor markers, and if possible, I would like to I'll ask the radiologist to put in a needle somewhere and get some tissue. Not that my decision will depend on it, but we have to establish in some way that we are dealing with a malignancy. So these are the three things I will do.
So if you feel that there is nothing else but a large distended appendix, would you still want to put in a needle in that distended appendix? I mean, this is.
I thought I saw some lesions around the liver.
Yeah, so probably if it is there,
I
then
thought there was some, deposits around the liver.
Right. So these are the tumor markers. They are normal. Obviously, colonoscopy, like you said, would be done, and colonoscopy is also normal in this patient. So this is what. So the final, Neeraj, I mean, so we have done the desired workup here, and what we could find out here is that it's just a large distended appendix. The orifice of the appendix is normal. The mucosa of the cecum is absolutely normal. Tumor markers are normal. So what is, as per the radiologist, there is nothing else. Liver surface and everything else is normal. There is nothing. So what is your presumed diagnosis, and how are you going to proceed in this patient?
Dr. Asit, first thing first is that we can see that there is certain scalloping of the liver surface. There are certain deposits onto the liver. So that straightway goes in favor of pseudomyxoma peritonei and PFP, and there is a large distended appendix. So it would be a mucinous neoplasm of appendix with the pseudomyxoma formation over there. That would be the
right. So this is the picture intraoperative that you see. This is a large distended appendix here, if you can see on the right side picture, and there is nothing else in the peritoneal cavity. There is no mucin, there are no other deposits. Everything else is absolutely clean. So what is your next step here?
I would just really like to see the liver surface over there.
It's normal. It's absolutely normal.
So my next step would be,
there is no speck of mucin anywhere else.
So first thing I would just like to say that I have to counsel the patient first that it might be a pseudomyxoma peritonei when I am going to put a scope inside. And if it is not found, as in your case, we'll be doing a appendicectomy over here and subjecting it to frozen section, what I feel like. And if the frozen section suggests me it is a mucinous neoplasm and I have counseled the patient earlier before taking him up for surgery, then I'll be proceeding accordingly. Let me see what the report comes out to be. And we have to be very cautious. It is a very big mass, should not get perforated.
Right. So, Dr. Soumen, I would like to know from you. So this is almost a 11 centimeter long appendix, and it could not be, the base at the cecum could not be, could be established well, whether the base is involved or not, though colonoscopy revealed that the base is normal, the orifice is normal, but intraoperatively, the appendix and the base of the appendix at the cecum, we could not identify it separately. So what precautions would you suggest for a surgeon to take, and how would you proceed in such a case?
So first of all, the decision of doing a diaglab is a very good idea here. Number one. Number two, if you have done some biopsy prior to the surgery, and your diagnosis of mucinous appendix or appendicular neoplasm is established, then a different issue. So here, before going in for a surgery, you must counsel the patient that there might be subsequent surgeries which will be required, because doing a frozen section is not a very good option. I mean, it can help you in achieving a diagnosis, but there are a lot of subdivisions of appendicular mucinous neoplasm which is very difficult in picking up in frozen section. So here, the precaution the surgeon must take is in regards to the spillage of mucin. So at any cost, he has to stop the spillage of mucin. If you can see the base very well, then do an appendectomy, because there is no mucin deposit anywhere in the peritoneum. So that is a good thing. So you can if you can identify the base, do a proper appendicectomy, take out the whole specimen in an endobag, make sure there is no spillage. Now, if you have any doubt in the base, regarding the base, then I think there is a role of frozen to identify whether your base is involved or not.
So, Dr. Aruna, I want to have your views on this. So during this procedure, the surgeon found that the base of the cecum, he could not, he wasn't sure whether he will get a margin there. So he decided to proceed with right hemicolectomy. So to your mind, would you straight away proceed with right hemicolectomy in this patient? And do you think doing it laparoscopically is a good idea, or should this patient be converted to open?
So I think a right hemicolectomy might not be needed in this case. We can go ahead with a cecectomy or an ileocecal resection rather than going straight away with the right hemicolectomy, because the colonoscopy was otherwise normal. And to convert to an open, most important, as everybody has suggested, that there should be no spillage whatsoever. Though there could be perforation on a histopathological examination, but per se we should avoid spillage or perforation or rupture at all times. So we can convert to open, or at least take out the specimen through a small fan and steel and put a wound protector to ensure that there is no contamination anywhere. That is what I would do, and definitely not a frozen, because frozen, as said, would not give a definitive diagnosis. It might be confusing. So counseling the patient that a second surgery might be needed to decide whether it is a lamb or it is a ham or mucinous adenocarcinoma, to take a call whether we need to intervene for a second procedure.
Okay. So, Dr. Aditi, your concluding remark as to how would you proceed in this patient? So, intraoperatively, surgeon found that he would not be able to do an appendectomy in this patient. He won't probably get a margin there. So, is doing a right hemicolectomy justified here? And is doing it laparoscopically would be wise as per your assessment?
So regarding laparoscopy, it depends on the skill of the surgeon. Everybody is a laparoscopic surgeon, but the skill varies greatly. So if you are somebody who is not very comfortable with it and doesn't perform a right hemicolectomy otherwise, then it is better to convert it to open. But if you are very comfortable with laparoscopy, there is nothing wrong in performing the surgery laparoscopically. Another concern would be that you really have to explore the abdomen very thoroughly during laparoscopy. That is, turn the patient from side to side, look at the right paracolic sulcus around the liver for any mucinous deposits. And I agree with Dr. Aruna and Dr. Soumen that in this patient, even I would not go for a frozen section, but just counsel the patient that a second surgery may be required. Because just based on this appearance, it is very difficult to say whether it's a high grade or a low grade tumor. So
Agreed.
yeah.
So see, since we already know that we won't be able to get away with an appendectomy here, because possibly there is the margins, you won't get a clear margin by just doing an appendectomy. You have to do either a limited resection, say an ileocecal resection, or maybe a right hemicolectomy. So if you feel that anyways you're going to go with a section here, so might not as well do a right hemicolectomy so that that removes all the future concerns. Won't that be a wiser idea here?
I mean, it is an unindicated right hemicolectomy. Surgery, though we perform it all the time, but it is still resecting the right colon. So if it's not indicated just because, just to get a clear margin or a clear base, I would not perform a right hemicolectomy. And I always, I would want the pathology on this patient, because suppose it comes out to be a MAC, then I would do an open surgery. I would not manage this patient laparoscopically if it is a high grade tumor. Even if I'm able to perform a right hemicolectomy very comfortably, because we have to search for peritoneal disease, we have to do a proper omentectomy. So suppose you remove this appendix and you just fire a stapler on the cecum, do a partial cecectomy or a ileocolectomy, and then you get the report of a MAC, then you have to go in this patient. So I would try to do the minimum, get a proper histological diagnosis, and tell the patient that based on the pathology report, we may have to go in again. Another surgery may be required.
Perfect. So message is absolutely clear that you make all attempt to get a clear margin, do minimum to attain that, and make sure there is no mucin spillage at any cost. There is no perforation of the appendix, and get away with that. However, patient, the surgeon in this particular case decided to go ahead. This is the operative findings, that this mass was almost 12 into 6 centimeter, and this seems to be arising from the cecum bar appendix. There was no peritoneal deposits, no omental deposits, no ascites, or no any mucin deposits anywhere. This particular patient, surgeon decided to proceed with laparoscopic right hemicolectomy here. Now, this is the final diagnosis, that it's a low-grade appendiceal mucinous neoplasm, and it turned out to be PT3, and the margins were all clear since it was a right hemicolectomy. But yes, the message is very clear here that this possibly was an overkill in this patient. He could have gotten away by a small limited resection or an ileocecal resection. So this was the first case. Now we proceed further to the next case. This, again, a 47-year-old lady. Again, general condition was good, and she was being worked up for lower abdominal pain and frequency of urination. Detected to have a left-sided ovarian cyst or a cyst adenoma, and she was planned for a laparoscopic ovarian cystectomy. Now, during intraoperative, what they found out was that there were multiple mucin deposits on the peritoneal surface. There is an appendicular lump, and there is a large ovarian cyst. So what do you think should be the approach for this patient. This patient is on table and being done by a gynecologist. So what do you think should be the approach? Dr. Neeraj, I want your opinion on this. What do you think should be the best approach?
I just feel because the patient is on table and there are multiple mucinous deposits over there, so it can be very well from ovary or can be from appendicular both. So because the patient is on table, PCI 14, I would just like to take the biopsy of the patient. It is being done by a gynecologist for an ovarian cystectomy. So do the minimum, come out with a biopsy and just let us see what the biopsy is like, and then we proceed accordingly further for a second surgery.
So when you say take the biopsies, take the biopsies from where?
From the mucinous deposits.
Yes.
Not touching the appendicular or the ovarian cyst.
Don't touch the appendix, don't touch the ovarian cyst. Take the biopsies from the mucinous deposits or from aspirate the mucin, subject it to cytology, take the multiple biopsies from different quadrants and do a proper PCI. So I think the same thing happened in this patient. This patient, the oncosurgeon was called to just have an assessment. They did a detailed PCI evaluation of this patient. Multiple biopsies were taken and mucin was aspirated and sent for evaluation. Now, this is the report of the mucinous deposits. Now, peritoneal fluid aspiration, peritoneal biopsy showed acellular mucin with mesothelial reaction, negative for atypical epithelial cells or malignancy. Peritoneal fluid, mucin containing cells. Again, this is a cellular mucin, but there is no ATP or anything found here. Now, Dr. Soumen, what would you do from here next?
So there is a confusion that now you have a diagnosis of mucin, cellular mucin inside the peritoneum. So in the primary setting, if you have a well encapsulated appendix and you could have removed it, then the situation would have been little different. Anyways, from current now, this is a condition where you have a PCI 14 and you have a diagnosis of appendicular mucinous neoplasm. Now we don't know whether it is MAC, LAM or HAM. Okay, so that is a point where you need to decide whether I will go in and do a CRS HIPEC or will do CRS only. So possibly because of the PCI is 14, I would like to prepare the patient for a proper CRS and HIPEC.
Agreed. So this is what you feel should be done. Now, before we proceeded, we decided, though there was a diagnostic laparoscopy done, a repeat imaging was done for this patient, just to make sure that we are not missing out on anything. A CT showed some scalloping around the liver, and there are deposit in the, you can see there would be a mucinous deposit. The port sites you could see, there are some, now there are already some deposits in the umbilicus, and there are this large cyst in the ovary. Right. So patient was counseled accordingly that she would require, these are the findings of the CT scan. Now, tumor markers were done again. Like you said, you should do all the 3 tumor markers. So these were the tumor markers that were performed for her, and tumor markers were all within normal range. So the next approach would be surgery. Now, Dr. Aruna, I would like to have your opinion here. So what kind of surgery would you plan for this particular patient? Do you think HIPEC is mandatory in these circumstances? And if you do HIPEC, what would be your protocol of performing in HIPEC in these patients?
So looking at the CT scan as well as looking at the laparoscopy findings, it looks that cytoreduction, a complete cytoreduction is possible. So after properly counseling the patient and preoperatively building up the patient for the necessary surgery, including a peritonectomy, we would go ahead with a cytoreductive surgery as well as HIPEC. Because studies have shown that in mucinous appendiceal neoplasms with peritoneal spread, HIPEC definitely has advantage. And we prefer to use the drug mitomycin C and at 10 milligram per meter square. And we use it for 90 minutes. That's how you would proceed.
Right. So would you want to do a right hemicolectomy in this patient upfront, or along with the bilateral salpingo-oophorectomy with total abdominal hysterectomy, or your approach would be any different?
Considering that there is still no definite evidence for if there is disease in the right hemicolon, in the right paracolic region, which requires a right hemicolectomy, yes, I would go ahead with a right hemicolectomy. Otherwise, proper pelvic peritonectomy, a TH, BSO, appendicectomy with the negative margin, as well as the areas of peritonectomy which have disease intraoperatively, this is how I would go ahead. I wouldn't straight away go ahead with a right hemicolon in this case. I wouldn't go ahead.
Right. So, Dr. Aditi, in such scenarios, would you recommend a total peritonectomy, or would you suggest only peritonectomy limited to the disease? What would be the approach here? What should be the right?
First, I have one point to make on the first surgery. So the gynecologist has called you in, and if you feel you can remove the appendix easily with a clear pace, then I would like to perform an appendicectomy during the first surgery, because we are not opening up the retroperitoneum, and it would give us a definitive diagnosis on what the appendiceal tumor is. Like I said, it could be a MAC with acellular mucin and low-grade tumor in the rest of the abdominal cavity. But if it's a MAC, a right hemicolectomy will be required. So that would be my take on the first surgery. And regarding a total parietal peritonectomy, there is, in most of these tumors, if you explore the abdomen carefully, I'm sure there is disease on the right diaphragm. And there will be disease in the right paracolic gutter, in the pelvis. You are doing all those peritonectomies and omentectomy. And if you explore carefully, a lot of times you will find disease on the left side too. With this PCI of 14, I'm sure this patient as such will require a total parietal peritonectomy. Now, if the disease is just confined to the right side, we have in our own data, Indian data and as well as French data, we found that uninvolved regions had microscopic disease in 25% of the cases, more than 25% of the cases. So I would personally perform a total parietal peritonectomy. But again, it is, there is no standard recommendation for that. There are some people who would not perform it, but there are some people like me who believe that this disease, there will be a lot of microscopic disease in the rest of the parietal peritoneum, and I would do a total parietal peritonectomy for this patient.
Right. So I think this is what we follow at our center for these mucinous tumors and the patients who have these pseudomyxoma peritonei. We treat them as the disease of the peritoneum, and we prefer to do a total peritonectomy in all of these patients, as compared to, say, if you are dealing with a colorectal primary or a gastric primary, then you end up doing a limited peritonectomy. But in these cases, in our center, but we prefer a total peritonectomy. So this is what this patient has undergone. This patient underwent a right hemicolectomy, total abdominal hysterectomy, bilateral salpingo-oophorectomy, and total peritonectomy, plus HIPEC with mitomycin C. And these are some of the intraoperative pictures. There were some nodes in the mesentery of the right colon, and the disease, which was almost everywhere, including the liver, and it required almost a complete glycinectomy. And this is the end result after the total cytoreductive surgery. And this is the final histopathology here. So it turned out to be a low-grade appendiceal mucinous neoplasm. There is no invasive malignancy anywhere. And the mucin which we saw was also an acellular mucin. The ovary had the benign mucinous cystadenoma again. So it had two simultaneous mucinous tumors, one in the ovary and another in the appendix. Do you and rest of the deposit all had mucin, but all the mucin was acellular mucin here. So do you think what we did was an overkill, or was it justified? I mean, like you said, doing a right hemicolectomy probably could have been avoided. Was CRS was HIPEC could have been avoided in this patient. So what's your opinion on this, Neeraj? I want to know your sentiments on this.
I feel that it has not been an overkill. An appropriate treatment has been done for the patient. It has come out to be lamb with certain mucin and abdomen and have been done correctly. I feel that further the patient needs to be followed up regularly.
Okay. Any further treatment required for this, Dr. Soumen, in your setting? Do you think you would want to give any adjuvant therapy to this patient?
Not really. For lamb completely resected, I don't think any adjuvant therapy is warranted.
Right. And what is the follow-up protocol you follow for these patients, Dr. Aruna?
So we follow up for every 6 months for the first few years with tumor markers and ultrasound. And if any tumor markers are elevated, then we get a CT scan. Absolutely, first is the clinical examination as well as a history to know if there are any symptoms like abdominal distension or any other symptoms which may merit a tumor marker with a CT scan at the same follow-up.
Right. So 6-monthly follow-up with a cross-sectional imaging and a follow-up. That is what is to be done. Yeah. So that's what exactly we would do for the patient. Right. Now let's come back to the last case again. A 63-year-old lady, good general condition, again evaluated for abdominal pain and constipation. This is the CT scan of this patient, again scalloping on the liver, and some of the deposits, the omentum seems to be involved more than in the previous cases. There is some deposits along the right and the left paracolic gutters, and there is a lesion at the cecum involving the appendix. Now, for this patient, there were also bilateral adnexal masses and small ascites. So to have a diagnosis, would you do an FNAC, or you think a biopsy is a better thing to do? Are you happy with FNAC in such patients, or you would insist on a biopsy, Dr. Aditi?
So I think a true-cut biopsy is what we do. FNAC is no longer done. And the radiologist would look at an area where there is some solid component, and that is easy to biopsy and perhaps biopsy that.
So unfortunately, we could not biopsy anything because other than the adnexal masses, there was hardly any solid component. So we end up getting just an FNAC, and FNAC said there is mucin secreting tumor, and there were deposits of adenocarcinoma. So the biopsy revealed that it is a mucin secreting adenocarcinoma, mucinous adenocarcinoma. So what next? What is your approach in this patient next, Dr. Aditi?
So in the biopsy is a mucin secreting adenocarcinoma.
Yeah.
On FNAC.
Yes. So they could see some of the high-grade dysplastic cells in adenocarcinoma. That's what they said. It's a malignant cell, and they proposed that it's a high-grade tumor with mucin. So probably an adenocarcinoma.
Okay. So I saw that there was an omental cake, as you had mentioned. So maybe a true cut could have been done from that. But I would go by the imaging, and If the disease seems to be completely resectable, then I would go ahead with surgery in this patient, because even if it is a mucinous adenocarcinoma and there is peritoneal disease, there are ovarian mets and it is completely resectable, the treatment is cytoreductive surgery and HIPIC. So if a colonoscopy is not done, the colonoscopy has to be done for completion. And the treatment is surgery for this patient.
So upper GI was done, which was normal. Colonoscopy was done, which was normal. Tumor markers are all normal as per the protocol. This is being done for all the patient. Now, since it's an adenocarcinoma, I mean, it's a high-grade tumor, not a LAM or a mucinous.
I'm not convinced that this is a adenocarcinoma, because sometimes, just on cytology, some atypical cells, to call it an adenocarcinoma, a histopath is required. Cytology is not enough. So I would, give more importance to the imaging findings and try to determine whether it's truly a high-grade tumor.
Okay, so let's get a little hypothetical twist to it. Say you've done a biopsy and you could prove that it's an adenocarcinoma. Would you consider giving neoadjuvant therapy to this patient or not?
If the disease is completely resectable, then it has to be surgery first. As such, there is no benefit of neoadjuvant chemotherapy. In fact, there are some studies that have suggested that patients who receive neoadjuvant chemotherapy have a poorer survival.
Right.
Of course, we don't have
Neeraj,
any data on it.
Right. So I think these are the two approaches that patient takes. There are two schools of thought. Some says if you have a high-grade histology, especially if you have, say, signet ring cells, then possibly it probably merits a neoadjuvant therapy. But like you said, there are other school of thought which says that giving a neoadjuvant therapy has a poorer outcome because patients are usually run down by the time you take them up for cytoreductive surgery. So Neeraj, what would be your approach here, and how would you take this patient up further?
The PCI of this patient appears to be pretty high. It must be more than 20, 22 or so. If
this is the PCI.
27 you are writing over here. So if the disease is resectable, I would just go for cytoreductive surgery and HIPIC. And majority of the times you are able to remove the tumor completely with a total peritonectomy. Maybe you will be requiring 1 or 2 organs resection. But if CC0 or R0 can be achieved, that should be the approach. I would go with that.
Right. So you also believe that giving neoadjuvant therapies to these patients is not the right approach, even if you are.
What I feel over here is that the tumor most likely is coming from the GI tract. It's not coming from the ovary. As CA125 is normal, so it is most likely coming from the GI tract.
So it's, radiologically, it's an appendiceal tumor.
So neoadjuvant therapy in such a case has not shown to be any improvement in the survival. Had it been ovarian mucinous adenocarcinoma, it would have been a different thing that you go with the neoadjuvant. But in such a case, I will not go with the neoadjuvant. I'll just go straight with the CRS.
Right. So this patient underwent cytoreductive surgery, CRS and a HIPIC. Dr. Soumen, so what approach for a cytoreductive surgery do you follow? Do you prefer a transperitoneal approach or an extraperitoneal approach for CRS? Do you choose one over the other? And if so, how do you do that?
Most of the cases we do with transperitoneal approach. Very few cases where you need you have a previous incision, it becomes very easy to go inside the peritoneum and doing the surgery. So we routinely do transperitoneal CRS.
Okay. So Dr. Aruna, since this patient had a high-grade pathology, would you do a diagnostic laparoscopy to make sure that your small bowel is free? You
Absolutely.
would be able to do a CT0 before you do a laparotomy to these patients?
Absolutely. I would definitely, in our center, this is what we do. Whenever we see that there is extensive disease on the scan, though that it looks resectable, there are chances that the small bowel disease and small bowel mesenteric disease might be missed. So it is always better to put in a scope before we go ahead and take a full laparotomy. And once we are sure that the disease is resectable, then just go ahead with the laparotomy and cytoreductive surgery and HIPEC.
Right. So, Dr. Aditi, can we have some tips from you on how you would approach such a patient? I mean, how do you choose transperitoneal versus extraperitoneal? Do you always resect the umbilicus? And would you do a diagnostic laparoscopy prior to proceeding? And in which cases would you prefer that?
So in most of the cases of PMP, I would not perform a diagnostic laparoscopy, even with advanced disease, because there is a huge omental cake and it largely limits your laparoscopic evaluation. So you are not, and even if you feel the bowel is normal during surgery, you would find you would find some nodules on the small bowel. So most of my patients will not get a diaglap. With the CT scan and peritoneal MRI now, we can have a fair amount of judgment based on whether the patient is symptomatic or not, and the level of the tumor markers and everything. So if I have a doubt that it will be completely resectable, then I will counsel the patient accordingly. If it's a low-grade tumor, there is a definite role of debulking surgery. So you will have to debulk this patient. So surgery is required anyway. And I would counsel the patient that this is the probability of a complete CRS. If it is a high-grade tumor, again, even in a borderline resectable case, the surgical attempt is valid, and most of us would prefer to attempt a cytoreductive surgery. With prior imaging and everything, you can tell with a fair amount of surety whether you'll be able to get a complete cytoreduction or not without performing a diaglap also. So regarding extraperitoneal and intraperitoneal approach, I think the advantage of extraperitoneal approach is that in areas like where in the pelvis you cannot make out one structure from the other, it's very easy to get onto the right plane and remove the tumor, and it goes very fast. So most of the times I prefer to go intraperitoneal. Initially, if I have a doubt about the resectability, I would make a small mini laparotomy and have a look at the small bowel. It is always easier to look at the small bowel like that, or make a peritoneal window. And the advantage of the intraperitoneal approach is that a lot of our some of our more experienced surgeons like Dr. Sugarbaker, Professor Yonemura, they recommend extensive intraperitoneal lavage prior to beginning the cytoreduction. So if you do the intraperitoneal lavage, you can intraperitoneal transperitoneal approach, you can do that. So I don't think it matters so much unless you have to decide on resectability. Then there is no choice but to go transperitoneal. If you are going to decide intraoperatively on operability, what to resect or not, then it is worthwhile going transperitoneal first.
Right. So this patient underwent CRS and HIPEC. Unfortunately, she developed pulmonary thromboembolism on post-op day 9. She was managed, and she was eventually discharged on day 15 from hospital. Final histopathology is mucinous adenocarcinoma and arising from the appendix, and it was involving the greater omentum and parametrium along with the bilateral ovaries. So we could achieve a CC0 in this patient. Now, what is the role of adjuvant treatment in this patient? Would you refer your patient for adjuvant therapy since it's an adenocarcinoma? Neeraj, what is your take on this?
I would send my patient for the adjuvant therapy in this case.
Right. So depending upon the grade of tumor, I think these patients should receive adjuvant therapy. We have already discussed the role of neoadjuvant treatment. So to my mind, I mean, the grading of the tumor does have a role on whether you should give neoadjuvant or not, especially if you have a very poorly differentiated tumor or a signet ring histology. we usually prefer to give neoadjuvant therapy in our patients. Rest of the patients undergo upfront surgery followed by adjuvant therapy if we detect a high-grade tumor later on. So I think I would like to thank all of you for your valuable time, and it was an eye-opening session for me. I learned a lot from such experts of this topic, and it really enriched me. It would have definitely helped our students, and I think we have stretched ourselves beyond our mandate, and I would not take much of your time, and I would want Dr. Shefali to conclude the session.
Yeah.
And thank you, all of you, for your valuable time. Thanks.
Thank you, Dr. Asit. Thank you, all of you. I mean, such a wonderful session on such rare malignancies. So we were already looking forward to something new to learn. So just one question, as I posted also. So apart from mitomycin, do you use any other drug during HIPEC? And any comment on doses? There are so many papers highlighting the dose. I mean, we are never on a conclusion, okay, what is the optimized or standardized dose you use for chemotherapy in HIPEC? Any comments on that? Any of you, Dr. Aditi, Dr. Soumen, Dr. Aruna, any of you, or Dr. Neeraj, any of you?
Aditi would be in the better position to answer this question, but this is a perpetual problem, what the dose and what the duration. But as a surgeon, most of us would like that at least the duration should be 90 minutes.
Yeah.
I mean,
Absolutely.
do you think there is any confusion left in it? I mean, for most of the GI tumors, after the experience and the data that we have now, 90 minutes and mitomycin C would be a preferred approach for at least appendiceal and colorectal cancers. I don't think there is much.
No,
With the pseudomyxoma, it is a different
I'm not
thing.
asking for the choice of drugs, because in GI malignancies, for that matter, pseudomyxoma, you have mitomycin as the preferred choice, or if you cannot use, you may have an oxaliplatin as a choice. But about the doses, there is never a consensus. What papers did we find out? So that is why.
Medical oncologist हो के हमसे पूछ रहे हो.
Yeah, आप expert हो. Any comment if you can make, that's always welcome.
We no longer use the 460 milligram per meter square because of the toxicity, and there is the Wake Forest regimen of oxaliplatin of 200 milligram per meter square for 2 hours. Now, most of us have moved over to mitomycin C, and with that recent paper in JAMA surgery, mitomycin C and cisplatin. Though it was a retrospective study, propensities co-matched with all the limitations, there was a benefit of mitomycin C plus cisplatin. And again, a lot of the more experienced surgeons feel that a combination of drugs is better. So mitomycin C and cisplatin is very well tolerated. 25 milligram per meter square or 15 milligram per meter square of mitomycin C and 50 milligram per meter square of cisplatin.
Cisplatin, very correctly said, because in gynecological malignancies where we are sure that it's the ovarian origin, we generally use cisplatin according to 75 milligram per meter square or 150 flat dose. That's the consensus we have reached there. But for mitomycin and all, we tried to find out a consensus, but the doses vary according to the center what they use. So anyways, it was a wonderful discussion. Thank you, all of you. And we'll carry on the webisode next time with a new topic. And just for your information, we have recently started the Max Institute of Cancer Care Twitter handle, where we'll be linking all our webisode sessions for that matter for your expert comments and on. Thank you so much for joining.
Thank you.
Thank you, everyone.
Thank you.